लो
सर ज्वाइन कर लो सर।
काम किया what is problem
Hello.
सर
Hello.
somebody activating panel group mobile
I can't see the screen though. Yeah.
Nehal madam what is problem
Sir, suddenly I was the host and my internet gone off. तो मैं वो change कर रही थी internet and then it was ended.
Okay, okay. I thought what happened.
No, no. वो मैं net change कर रही थी and it ended.
कोई
संजीव
बात
सर ने
नहीं।
संजीव सर ज्वाइन कर लेगा।
Yeah.
I'll tell Sanjeev sir to join.
Sanjeev sir has not joined.
We are waiting for him only. Lata is calling him.
Yeah. I'll just call it.
આ શું થયું પ્રશાંત ને?
મને કઈ નથી થયું.
Sir,
આ
is
તો-
joining. Sir is joining. Just now I called him.
આ તો મારો અવતાર હોય એટલે સારું રહે એમ કરીને.
પ્રશાંતના બહુ બધા અવતાર છે સાહેબ.
આપણે રેકોર્ડ થાય છે. હા.
हेलो।
Yes, sir, you're audible.
Yeah. So that's why I'm telling you, when you make a diagnosis of epilepsy syndrome, you can prognosticate and treat accordingly. So many things we have seen where infantile spasm will be diagnosed and myoclonic epilepsy, sodium valproate will be started, but they don't respond. If you make a correct diagnosis of the epilepsy syndrome, then you start the correct medication and it will be helpful. Secondly, prognostication is very important. Some of the epilepsy syndrome, it will be very difficult to treat. It may land up in a drug-resistant epilepsy and like Weiss syndrome, LGS, and some syndrome like SELECT, which are benign, will gradually resolve, may or may not require treatment also. Therefore, it is important to make a diagnosis of epilepsy syndrome wherever it's possible.
slide is not moving
Sanjeev sir?
Sanjeev sir.
Sanjeev sir is muted. Sanjeev sir, kindly unmute yourself.
हो गया हाँ.
हो
So
गया
the
सर।
core is electroclinical correlation for the epilepsy syndrome. Other things already elaborated by Dr. Debashish. Quickly, Dr. Abhijeet, what is the role of EEG in epilepsy?
Yeah, thank you, sir. and Good
Is
evening.
number one thing, Abhijeet, is EEG is a diagnostic test of epilepsy?
No, of course not, because always
Not,
when we
yes.
have a normal EEG, there is always a footnote what we
Okay.
always write. A normal EEG
Okay.
doesn't rule out the
Okay.
epilepsy. So here I start. So EEG, of course, is one of the crucial investigation for epilepsy, but not always a normal EEG would rule out your epilepsy. Now, what I will emphasize more is technically done right and appropriately done, and at a good center, interpreted by a good EEG. A neurologist is important thing. What we need is a good sleep, awake, and HVN photic, which has to be inculcated in the EEG, which will give the yield of the EEG little more. Those are the activation procedure, what we call. And something which is called as video EEG, where we incorporate the video with EEG along with it, which gives us the edge on are the attacks are epileptic, non-epileptic, what is the onset, what is the kind of evolution of this, and there are certain epilepsy syndrome, as Debashish already mentioned, there are, classical signature. So for example, GG, genetic generalized epilepsy, what we have 3 Hz and spike in childhood absence, we have juvenile myoclonic epilepsy, we have polyspikes and other things. Of course, EEG doesn't take you through the journey of the epilepsy, so we don't tend to keep on EEG for the prognostication. Only a epileptic encephalopathy, for example, LGAS or hips spasm, or those patients, we know whether the development and the seizures and the EEG is correlating or not. And as I always say, all epileptic patients 10 to 20 would have, normally EEG, versus in normal population, you have 10% of the EEG which shows the abnormal variant. So the EEG investigation has to be taken up.
That is the most important takeaway from Dr. Abhijeet. So even if you have a slightest doubt that that paroxysmal event was not a seizure activity, please don't do EEG. If you have a setting for syncope, if you are viewing that it is a psychogenic non-epileptic event or any other event of the infant, please don't do EEG, because 5 to 10% may have some spiking and slowing. So we have to treat the patient, not the EEG. Thank you, Abhijeet. Quickly, Dr. Debashish, what are the indications for neuroimaging, and which neuroimaging you will prefer in while evaluating a child with epilepsy?
Yeah, definitely.
Please.
In many cases, neuroimaging is important, and MRI is the preferred neuroimaging. In only in emergency situation like head trauma or something, or you expect calcification, sometimes you can go for CT scan, but otherwise, most of the cases, MRI is important, not an urgent, non-emergent is also fine. Especially 3-4 scenarios, it's more important when you have a focal neurological deficit, when you have a focal seizure, any infant or less than 2 years child getting seizure, and EEG, you have a localization related epilepsy, or EEG shows a lateralization or localization. In this case, the yield will be higher. And certain epilepsy syndrome, like Abhijeet had mentioned, generalized epilepsy, like select, or like your childhood absence epilepsy, JME or select, you don't ask for an EEG.
Now
So
coming
those
to
are
the
for MRI. Yeah.
coming to the Dr. Anand sir, with wearing a spectacle of a general pediatrician, what are the basic principle of starting a newly diagnosed child with anti-seizure medication? What are the basic principle, Anand sir? 1, 2, 3, 4. That's all. Anand sir. Anand sir
Most
is not
important
there.
factor
Yeah.
regarding a treatment is that first you have to confirm it is epilepsy or not.
Sir, we have confirmed. Now you come to this basic principle.
Yeah. So most important basic principle is that minimal adverse effect of the drug, complete control of seizure. So we are to be start with a single drug, monotherapy is the role. So we should know the pharmacodynamics, pharmacokinetics, adverse reactions, and all these things we should know. So we have to start very low and very go slowly, so that we have to start with one drug at a time, and you have to reach the maximum level before stopping it, because there are tendency to frequently change that should be abandoned. So once you get maximum dose of a single drug, then if seizure is not controlled, then you can think about another drug. And of course, yeah, there will be a definite drug difference between focal seizure. Then I already mentioned in the case of epilepsy syndrome also, different drugs for different seizure disorder.
Okay.
So you have to make that our drug given is very proper drug. Company is very important, and they are taking regularly, especially during the school season. There will be chance for missing. Of course, we have to avoid all the provocating factor because that is very important.
Okay.
So we have to say.
To sum up the things, Anand sir has told, monotherapy should be the rule. The dictum should be start low and go slow. But of course, there are certain exceptions. Like if the first presentation is status epilepticus, then you have to load with the full therapeutic dose. And of course, you have got a liberty with the drugs like levetiracetam and the company, the other derivatives of levetiracetam. You can start on the full dose right from the day one. Now, coming to Tarun, what will be your variables, or what were the variables of choosing an anti-seizure medication? Very quickly and precisely, please, because I have to jump to cases now.
This typically depend upon the seizure type. It's a focal generalized absence as well as the epilepsy syndrome. There is a certain epilepsy syndrome, certain drugs are working. That's a very specific. And the other is the patient specific, like in genetic background, like in Asian population, if HL is something, then there tends to be a carbamazepine induced Stephen Johnson syndrome. Sometimes that happens. And then there is an age and gender specific. You like a neonate, you start certain drugs, you don't start valproate at the neonatal age, as well as the gender. As an adolescent girl, there's a problem with the valproate, so you don't start that drug. And there's a comorbidity. If there is an obese patient, so then you don't start that drug which increases the weight, as well as the co-medication. Don't combine the two old drug, or the patient have an anti-tubercular therapy, or there's a chemotherapy, and you start anti-enzyme medication like an AED or valproate or carbamazepine. Then the level of the chemotherapy or level of the drug is not achieved. And other is nation specific, like an AED availability. Before that,
Okay.
we have difficult to get Vigabatrin is available. Initially, Sapril was a costlier drug. Ethosuximide is available now. Initially, we don't have an ethosuximide, and sometimes we take the cost of the drug also. So these
So
are the
very nice,
variables in choosing
very
the.
nicely elaborated by Tarun. What are the variables for choosing an appropriate ASM for that particular epilepsy? Now coming to our first case, Debashish, 6-year-old, started his abnormal movements, right face, right hand. Child appears to be conscious. No relevant past history, no trauma, no fever, and no any past history of similar episode. A 6-year-old child. Okay, just look at those moments. And Debashish, how will you elaborate this? The seizure type. Would you go ahead with EEG and neuroimaging? Neuroimaging is priority or EEG is priority, and what will be the ASM of choice? Debashish. Just
Yes,
one,
sir.
two, three, four.
Yes, yes, sir. So if you see that the video you have seen, so there is a jerking of the angle of the mouth and face of the right side along with some twitching of the right hand that we can see in the video. So it's most likely it's a right focal seizure with preserved consciousness. It looks like the child is conscious or aware during the episode. So definitely the dictum when you get a focal seizure, EEG and neuroimaging, both should be definitely done, and we are expecting some focal discharges in the EEG, in the EEG and something in the MRI. So if you look at this MRI, so you can see in the middle there is a contrast enhanced MRI. This is a ring enhancing, single ring enhancing lesion. Is there here? There is a lesion, T2 hyperintense lesion with perilesional edema. And if you can see the sagittal image, there is a T2 hyperintense lesion and is a black dot in that lesion also, which probably it like a Scolex also. So single
So
lesion
NCC.
ring enhancing, so it's more likely a
NCC.
NCC or a
Okay. Okay.
neurocystic psychosis.
Anand sir, the monotherapy for focal seizure, what are the drug of choice? with the
Yeah.
best evidence?
Historically, we know the drugs for the focal seizures, carbamazepine or newer derivative like carbamazepine. And phenytoin and nowadays not people are much using, and tocopherol also you can use. And if there is a not control, then you can use lamotrigine or levetiracetam. But
Okay.
lamotrigine,
Thank
the
you.
adverse effect, we are
Thank you,
be
sir.
concentrate.
Thank you so much. Thank you so much. Now, again, another scenario, Abhijeet. Again, this is a focal sort of seizure. This is a 6-year-old male. रात में मतलब सोते वक्त ये माँ बाप को, पेरेंट्स को रूम में से आवाज आई, ऐसे कुछ गर्गलिंग साउंड निकाल रहा है बच्चा, और वो थोड़ा सा he was not responsive also, and there was some you look at the right eye and a lip.
Yeah.
This
So-
is a nocturnal event.
True. So
Okay.
the history itself is leading you, as you say, the path. So basically, a normal baby with normal neuroexamination, normal birth history, no deficit, normal school going age, a nocturnal guttural sound, some focal and some eye twitching and semi-responsiveness. So we are looking at like benign Rolandic epilepsy, what we used to call earlier. Now the nomenclature has changed, and now we call this as select, which is self-limiting epilepsy of centrotemporal spine.
Centrotemporal. Okay.
Yeah,
Very
exactly.
nice.
So this
Now, how do we proceed further, Abhijeet, with this
Yeah, exactly.
particular
Because the
semiology, age
Exactly.
group, and the timing of the seizure?
So now the investigation choice here is we need to get an EEG to know the classical hallmark on the EEG, what we have.
What precaution you will take before ordering
Yeah,
an
so
EEG?
we'll get a sleep and awake EEG, sleep
Sleep
EEG
and
must,
awake
because the sleep is activation procedure, and we'll get a lots of discharges running in, or they're coming in the runs in your sleep record. So as our slide classically depicts, what we have is the left centrotemporal spike, and even the morphology is very classical of, I mean those Rolandic discharges. Sometimes they are bisynchronous and they are mainly sleep activated. So in awake EEG, you may not pick them up. So now we have kind of come to the diagnosis. So a clinical scenario, seizure type and EEG type. Now the thing comes for a now treatment versus no treatment, right? And of
So
course,
the first thing is now, the previous case was also a focal one. This is also a focal one. Debashish emphasized on neuroimaging. Would you go in this particular situation when you have a classical electroclinical correlation, specific age of onset, and a specific semiology with a EEG correlate? Would you go ahead with neuroimaging?
Yeah, I would defer the EEG and I would see how the path of the epilepsy will go. So first, I won't do an EEG with MRI. I would just go get along with the EEG and would start.
So that is the beauty of identifying an epilepsy syndrome.
Yeah, very good.
So go ahead, Abhijeet.
So now, I mean, the main crux of this epilepsy is whether to treat or not treat, because now you are all IT savvy people or Google savvy people will come with you and knowing whether to treat, not treat, and number of investigation, I mean, n number of adverse drug reaction of medicine. So as we know, this is self-limiting epilepsy, so majority of them will outgrow. So only 10% will have only one seizure, few of them will remit by 12 years of age. So frequent seizure, longer seizure, lots of guttural sound, which is caused make or choking and kind of life-threatening things. On those patients, we may start, or recurrent episode, or if they start early, those are the patients we should start. But again, you have to give the option starting versus no starting. And if at all we are starting with EEGs, the focal seizure, so oxcarbazepine would be the drug of choice. But again, we can start with levetiracetam and sometimes valproate, and we can add clobazam.
So the treatment, every child doesn't need treatment. Only indication are frequent seizure and also a single daytime seizure, even if it is there. Of course, that would be another indication, and the most important indication would be parental choice.
True. Okay. And one more thing I would like to kind of say here, the epilepsy, no, but scholastic behavior has to be taken, because sometimes the EEG become worse and the child may have the scholastic or cognitive decline as well. So you have to be alert about it.
Okay. So in that situation, you may think of the things like CSW and all.
Yeah, exactly. So
the child is progressing for that, and also you would like to change the drugs to valproate-like thing.
Yeah,
okay.
Exactly.
Thank you, Abhijeet. Very nice. So doing diagnosis of epilepsy is not synonymous with treatment. This is an important message from this case. Now another very important semiology, Dr. Tarun. Look at this child, what he is doing. 7-year-old male started his abnormal movements with altered sensorium. You can see the lip movements, repetitive upper lip movement, preceded by headache and aura, visible since 2 weeks, 2 to 3 episodes, normal development. Only significant history admitted for febrile status at the age of 3 years, for which he took treatment for 6 months only. Tarun, you go.
Yeah. So you can diagnose epilepsy via history alone. Here the child has a history of febrile status, and now you look at the semiology. He has some automatism. This is the automatic movements like an orofacial, oromotor automatism, chewing automatism. And also he has a left-sided upper limb distal searching automatism with behavioral arrest. So it indicates the ipsilateral left side temporal lobe abnormality with history of febrile status is a left-sided mesial temporal sclerosis and the
So
symptomatic epilepsy.
what abnormalities you will find in EEG of this child? Like,
So this is interictal EEG. We find discharges in the mesial temporal regions like F7T3 sometimes. Sometimes interictal EEG is absolutely normal. Sometimes you found the rhythmic slowing over the mesial temporal region alone.
okay.
And sometimes it's a discharge is very deep. You can't record on the
Are
surface.
they easily treatable if at all your MRI showing something like MTS or
This-
all?
This is the symptomatic epilepsy, and sometimes,
Yeah.
most of times, they are drug refractory. If there is not
Okay.
controlled by the anti-seizure medication too, then you require the surgery to cure
Surgery.
that.
So-
For the
Yeah, that's what I wanted, that my august audience should listen from the master himself. That is a legional sort of epilepsy and a very ideal choice for surgical case. Okay. अभी another case, young girl again, 6-year-old, कहाँ खो गए हो? Girl was doing very well in the school, but since last 3-4 months she is going down on her scholastic performance. Teacher complained to her mother that she is not attentive in the classroom, and as she always seems to be daydreaming repeatedly. What do you suspect, Anand sir? Quickly from the history. Young girl, a 6-year-old. Anand sir. Dr. Anand Kesavan. आनंद सर भी खो गए क्या कहीं? कहाँ खो गए आनंद सर?
Yeah. In between, I think I lost connection.
अरे यार
I
आप
got a seizure.
इनविजिबल हो जाते हो कभी कभी. So please
Yeah.
comment on this story
Yeah, it is
and quickly give the diagnosis to the audience.
It is a common scenario in this age group. It is a case of, rightly pointed by some audience. It's an absence seizure, multiple times, several times in a day. And the teacher thinks that he is not attending. Mother thinks that the child is not good in studies, something like that. So it is a typical case of absence seizure. There is no loss of consciousness, no loss of posture, and it can happen several
What
times.
is the clinical test in the OPD? What is the clinical test?
It is a hyperventilation. We can perform hyperventilation very easy. In the OPD itself, we can do hyperventilation or just what he has shown, that child is blowing on a paper. So very good bedside test. So it is a very seizure type epileptic syndrome with very good prognosis. One of the epileptic syndrome with very good prognosis.
And this is the EEG. So every absence has got a signature on the EEG. And what is the signature, Anand sir?
Yeah, it is shown. It is, I think one of the even general practitioners can diagnose 3 spikes per second. It is a very, very characteristic EEG. I think EEG is characteristic. Clinical features are characteristic. Very good prognosis. We can very easily treat it also. So I think it is a very good.
So the syndromic diagnosis is childhood absence epilepsy with, there was one more semiology with little bit eyelid myoclonia. So what is the monotherapy for the absence seizure? Childhood absence seizure, CAE.
Widely described as ethosuximide. It is not freely available in India. So we are often treating it with valproic acid only. Very, very good response.
So my another question to Dr. Abhijeet, you have a scenario of a juvenile absence seizure and what will be your choice? Even if you have an availability of ethosuximide, you will prefer valproate or ethosuximide in a juvenile absence seizure?
Yeah, juvenile
Abhijeet.
absence epilepsy is little tricky to treat and maybe sometimes little kind of a drug refractory. So definitely valproate I will add, but again, if it's boy, I would go obese girl, obese boy, adolescent female.
Okay.
I would think of low dose valproate and may add lamotrigine over it.
Okay, thank you so much. Thank you. So, a very important take-home message from this case is going to give my all the pediatricians colleague to who look after the newborns. She's 8-month-old, born full-term, birth weight 2 kg. Obviously, IUGR baby got seizure on day 3, documented hypoglycemia, and NICU stay for 3 days. Developmental delay was there, and this abnormal movement started since last 2 weeks. Debashish.
Yes, sir. So, as you can see in this video, there is a flexion of the head and there is little extension of both the hand and flexion of the head. So, these are occurring in cluster. You can see there are 2 to 3 in this video itself. So, this is typical infantile spasm or flexor spasm, or we used to call salam spells. So, sudden flexion, extensor, or mixed flexion, extension of proximal and truncal muscle, fasting for. So, when you see infantile spasm, 3 things are very important. It usually happens in cluster. एक बार जब भी होगा बार बार होगा, सो के उठने के बाद फीडिंग के टाइम में ज्यादा होता है, और होने के बाद चाइल्ड का बिहेवियर ग्रेजुअली चेंजेस. देयर इज ए न्यूरो रिग्रेशन मेनी टाइम. सो these 3 things are important to identify infantile spasm.
So there are so many things in this. Debashish has
Yes, sir.
nicely elaborated the semiology. एक तो there was a significant perinatal event in form of NHBI, neonatal hypoglycemic brain injury. Developmental delay was there. This semiology was there. So what is your next step, Dr.
Next,
Debashish?
yeah. It's an epileptic encephalopathy and an emergency to treat. Therefore, you will
Emergency
do
to treat.
Emergency.
This
to
is
treat.
very important. Listen, all the general practicing pediatrician, epileptic spasm is a medical emergency always.
Medical. So you will get an EEG immediately in this child. You can't say ki after 2 weeks we'll get an EEG. You have to get an EEG immediately and start treating. So this is the classical EEG signature. Up you can see normal sleep EEG with sleep spindles, but in when you can't tell, the background is not clear whether it's there's a chaotic background and there are multifocal spike wave discharges. So when you get a chaotic background with multifocal discharges, we call it the Hips arrhythmia pattern. It's the classical of West syndrome, but may not be seen in all the cases also. So even if somebody reports it as a multifocal thing, don't report it as Hips arrhythmia still. If your clinical feature, you are going to treat it. You can't delay the treatment.
And very important message to all my pediatrician friends. This is a classical NHBI. This was the MRI of this child in her neonatal age. A very classical neonatal hypoglycemic brain injury. This is DW image and this is ADC mapping. So please, I don't want to see such MRIs in our practice. So please avoid all the events of neonatal hypoglycemia to the best of your abilities. So the
Yes,
treatment
sir.
options 1, 2,
Yes,
3.
sir. Yes, sir. So just one line on hypoglycemia, sir. When once the child is hypoglycemic and there is a NSBI, it's very difficult to treat. So all cost hypoglycemia should be prevented. Bilirubin encephalopathy and hypoglycemia are 2 preventable causes of long-term morbidity. As you know, treatment is either high dose ACTH, or the AOCN paper also said that high dose prednisolone is also good enough to ACTH. So 4 to 8 milligram per kg of prednisolone, oral prednisolone is also effective. Along with that, if you can use ACTH 150 milligram per meter square or 6 unit per kg intramuscular daily. But one point is important ki it's a all and non treatment. You have to treat the spasm as well as treat the EEG also. So resolution of hips arrhythmia in the EEG is very important. So after 2 weeks, repeat an EEG and see whether the hips arrhythmia has resolved or not. So that's the end point of the that, then you gradually taper on your prednisolone or your ACTH. And if tuberous sclerosis, vigabatrin is the first choice. In all
Thank
other
you.
cases, ACTH is, and you can use it in combination also in studies or
So
difficult
important
cases.
take homes, it is a medical emergency, early EEG, early referral to the practicing pediatrician, starting whichever steroid preparation you have, preferably ACTH. But if you don't have ACTH, don't shy from starting high dose prednisolone, and see the response in 2 weeks. Repeat the EEG after 2 weeks, and if at all the epileptic spasms are secondary to vigabatrin, to the tuberous sclerosis, then vigabatrin is a precision medicine. Very important day-to-day challenging scenario. My request to all the esteemed panelists, be very specific and precise. 6-year-old male, case of a febrile seizure, history of fever 1 day, then started convulsion, continuing convulsion for about 30 minutes without gaining consciousness in between. Started with the left focal and then generalized. Now, okay, there was a history of febrile seizure on 3 occasions in the last 1 year. Okay, so this, with this history, what is this clinical scenario, sir? Anand sir? Anand sir,
History of febrile seizure. Now the
okay,
age
it's
is
a
6
febrile
years.
status. Okay.
Can you hear me?
Yeah. You are audible, sir.
So, history of febrile seizure in the past, and also now the child is 6 years.
Okay.
Most probable diagnosis, very consistently, it is febrile status epilepsy.
It's a febrile status. Sir, what is, according to the American Epilepsy Society guideline, the management of status epilepticus, but what is the updated ILAE definition of status epilepticus, specifically 2-3 lines, T1 and T2? What is the T1
Yeah, now
time and
though
T2
it
time?
changed the T1 and T2 means T1 is the time after which the sister do not terminate, patient will get some adverse reaction, and T2 means child has some neurological sequelae. So different seizure type got different T1 and T2 period are shown here because it is a absent seizure. It is a very long, 10 to 15 minutes, and T2 is unknown. But whereas in other cases like journalist chronic seizure, it is 5 minutes T1 and 30 minutes T2. So it is very
So very important message from Anand sir, and the other definitions by as per the ILE is what is established status epilepticus is status epilepticus that persists after the first line of attack, that is benzodiazepine, and what is refractory, which persists after the second line of attack. So sir, what is the what sort of treatment options you have for aborting an acute seizure episode? Dr. Debashish.
Excuse me,
Yeah,
Sanjeev,
yeah.
sir, sorry for interrupting you. I think we'll have to.
Just
time
last
is
case.
already-
Last
Yes,
case.
yes, sure.
Last case.
Sorry,
Okay.
sir.
So quickly, the first line of treatment will be benzodiazepine, maximum 2 doses, intravascular lorazepam. If IV route is there, or otherwise intranasal midazolam is available, it's a good option. Or intramuscular midazolam can be used. And in second line, if the after 2 doses of benzodiazepine, if the seizure does not stop, you go for any second line drug. All are good. Intravenous valproate, levetiracetam, or phosphenitrine. Anything can be used according to the availability in your unit or your unit protocol. It should be used. And anything after 2 drugs, if it is not stopping, you call it as a refractory and treat accordingly by anesthetic agent or intravenous midazolam infusion, like that. So very important is the benzodiazepine, and it works early. Therefore, early administration of benzodiazepine, maybe out hospital intranasal, is a very good, very important message.
And
Yeah.
intramuscular midazolam has got almost level A
Level
evidence as per the Rampart trial. And see if at all in an OPD practice, if you are struggling to find an IV line for a seizing child, please start intramuscular midazolam 0.2 mg per kg. And of course, the second line drug, I have already, Debashish has already told, they are all equally effective and equally ineffective. But the crux of the matter is start early benzodiazepine. If at all the benzodiazepines are delayed, the long-term morbidity and the need for ICUs and all they will be increasing and increasing only. So the early
now they-
benzodiazepine, full dose of benzodiazepine. So the dictum is hit early and hit hard.
Now sir, dictum is time is brain.
Time is brain.
Time is brain.
Time is brain.
Yes,
Time is
time
brain.
is brain.
So
Very important.
acting early
Very
is very important.
Very important. So thank you all my eminent panelists. I'm going to skip all this. Just one slide. Debashish, the indications of genetic testing in epilepsy.
Yeah, genetic testing is a very important. As you have seen, the causes, genetics is one of the causes. So any child, if your hypothesis does not fit to a structural cause or a cause you think, then it can be genetic, especially when there is a genetic history, small baby, multiple family members have epilepsy. So definitely, but we'll say ki any epilepsy where cause is not clear, a genetic testing should be done. And all practical purposes, whole exome sequencing is the one test that should be preferred initially. Shortly, if I say in just one line.
So we will sum up here. Thank you, my eminent panelists, for giving lot of important, delivering lot of important messages. This is very important slide for all those who are using left, right and center levetiracetam. लेवोटेरासिटाम अच्छा ड्रग है, लेकिन हर मिर्गी की दवा लेवोटेरासिटाम नहीं होती. Okay, so and this is I will conclude with this 7-step approach to seizure. Step 1, confirm seizure, rule out non-epileptic event with a good history and the video recording if at all it is possible. Then if it is unprovoked, step 2, identify whether it is unprovoked or symptomatic. Then evaluate with MRI and other investigation. Classify seizure type, history, clinical examination, EEG, MRI and other investigation. Step 4 is classify epilepsy type or epilepsy syndrome. Again, it will depend on history, clinical examination, EEG and MRI and other investigation. Find the cause of epilepsy, that is step 5. Step 6 is treatment, decision and treatment. And step 7, most important, is give more time than prescription to the family, that is counseling. Thank you so much. Every fit will not be cured by a single pill. So you have to have a special bullet for a specific type of epilepsy, and that is the story of 2025, which is called as precision therapy. Thank you so much, Team Gujarat and my panelists, and also the virtual attendees.
Thanks a lot, sir. It was wonderful presentation and a very good eye-opener for all, I think. Now I think we'll proceed for quiz with permission from Neil ma'am and Jankana ma'am.
Madam, if at all there are any queries for my panelists, so if at all they can take, if at all they are there.
Why not, sir? Yes, sir. Yes, sir. Why not? There are few queries. 1-2 questions were there. Is it true that Levera loading is now 60 milligram per kg, unlike previously where we used to start from 20 milligram per kg?
Anybody of you can take this. Anybody of you can take this.
So,
Tarun?
Okay. Yeah, it can be a 40 to 60 milligram per kg. You can load.
Okay.
So all the drugs that concept of all the drugs are similar has come from that Eclipse and Reset trial, and most of the trial has used 40 to 60. Therefore,
60.
Maybe 40 to 60 can be.
We start with 60 now. Okay.
Yes, sir.
Okay. Next.
So somebody is requesting to show Levera slide again.
See, that was an extrapolation of an adult study, which is called as SANAT 2, which clearly states that for a generalized epilepsy, of newly diagnosed generalized epilepsy, for a newly diagnosed focal epilepsy, levetiracetam is not a superior drug at all. The other choice of drug, they comes first, and then if at all you don't have option, then, or if you have a concern of comorbidity or co-medication, of course in that situation levetiracetam could be tried. But har mirgi ki dawa levetiracetam nahi hai. That's all.
It's a very mild drug.
Yeah.
Rest of the questions.
And yeah, bolo sir.
Sorry, sir. Rest of the questions Abhijeet sir is answering fastly on
Okay.
chat only.
Okay. चलो चलेगा. That is the better way to do it. So we can.
सर आप सब लोग भी रहिएगा हमारी क्विज में. 108
Yes.
friends. 108 is a helpline number of ambulance.
प्रशांत की क्विज है तो रहना पड़ेगा भाई.
So we will need your inputs also.
Yeah.
Okay. So thank you so much for such a nice panel. And now we will have a quick 20 minutes quiz. We are just starting the quiz. I just posted the link of the quiz and I'm sharing the screen. Out of 108, 52 have already joined, requesting others. I hope my screen is visible. Is it visible?
Not yet,
Fine?
not yet.
नहीं आई नहीं अभी तक.
ओके ओके सिर्फ एक मिनट दीजिए, ये मुझे तो दिख रहा है पर
The net
आ गया
slow
कि
होगा.
नहीं आया?
Now
it's visible.
visible, sir. Visible, sir.
अच्छा मैंने तब बंद कर दिया, आपने बोला विजिबल तो मैंने बंद कर दिया. एक ही मिनट. Okay, just a minute. As such, more than 60 participants have joined. Link है screen. I hope it is visible now.
Yes.
Yeah. So those who have actually played in past, they know that in this Kahoot platform, for a quiz, seeing at the last batch performance, we are giving 20 to 30 seconds only for the questions. There are around 30 questions and you will win prizes worth 15,000. And we are thankful to Zorvia for sponsoring this. From Zorvia, if Mr. Abhishek is there, he can just speak for a minute.
Yes,
Mr.
sir.
Abhishek?
Yes, sir. Good evening, all respected doctors. My name is Abhishek Kanyalkar. And on behalf of Zorvia Healthcare, I thank you for giving us this opportunity to be associated in such a wonderful initiative. Especially would like to thank Dr. Prashant KARIYA, sir, for giving us this opportunity to be associated with AOP Gujarat. At Zorvia, we are always at forefront when it comes to academic initiatives and scientific discussions. I would just take this opportunity to also mention that our pediatric brands have already come into the market, especially our Zorberry suspension, Zincase, Tasvia, which is levotropopazine, and Zorvin Kid, which is levosalbutamol 1 mg. We would request all the doctors, to support us, in our journey, because we are just about 2 months young, I would say, in this industry, and we would request all the doctors to help us in this journey towards building brands across the country through your valuable prescription support. Once again, thank you, sir, and thank you the entire team of Gurukul PATHSHALA, an initiative of AOP Gujarat. Thank you, sir, for giving us this opportunity.
Yeah, so thank you to our president, Dr. Jankna ma'am, secretary Nehal ma'am, and the main project co-incharge, Dr. Yogesh Parikh sir, and the convener Baldev Prajapati sir for giving me this opportunity. I'm starting the quiz now, and all the best to everybody.
All the best, everyone.
As usual, I request Dr. Lata ma'am and Dr. Nehal ma'am, please post in chat if somebody is asking for the game pin or the link so that more people can join. So just for a fun first question, choose one word which suits best to personality of Donald Trump. It's a Trump's mnemonic: talkative, reactive, unfiltered, media focused, powerful presence, and Donald Duck. So same way, the questions will be there, options will be there, and you have to just select one. For this question, there are no marks, but yes, you played well, and we have got almost all the different answers. So all the best to everybody. And the first question for the neurology quiz after such a wonderful panel is on your screen. Which is the first line drug of choice for neonatal seizures? Levetiracetam, phenytoin, phenobarbital, or midazolam? Sanjeev sir, if you can see in 10 seconds, we got 69, 70 answers. And the people are still answering. So this is the beauty of this platform. And the correct answer is phenobarbital, said correctly by 62 peoples. And the fastest finger first is Yo, who has given the correct answer. Second question. What is the most common childhood seizure type? Remember, most common childhood seizure type. A focal, absence, generalized tonic-clonic, or myoclonic? And 81 people have given the answers, and out of that, 8 are actually right. That focal is the most common childhood type. It is not the generalized tonic-clonic. Most common type is focal. Kronal is at the top, followed by the Vikas and Ginny and Chait. Okay. A double point question for you. Which gene is affected in Duchenne muscular dystrophy? Actin, a myosin, a SMN, and dystrophin. Because this is a double question, we have given 30 seconds and we got 80 answers in 15 seconds only. Requesting others to answer. If you are in the Zoom meeting and not joined still the quiz, you have to log into www.kahoot.it and game pin is 521312. So the 85 people have given the answers and 77 are correct. So it is dystrophin, and this Duchenne muscular dystrophy is an X-linked recessive disorder. Usually 2 to 3 weeks is the lifespan, and then there are certain gene therapies which have been also available. And now Vikas is at the top. Next question. What is the classical EEG finding in absence epilepsy? I told you, please listen to a talk. Spike and wave 3 Hz, a hips arrhythmia, a polyspikes, or a burst suppression. We got 85 answers, waiting for the others to answer. And the correct answer, that means, Sanjeev sir, the people have listened to the talk. Spikes and wave 3 Hz is the correct answer in case of absence epilepsy. And now Saimu is the top. What is the drug of choice for absence seizure? That is again said in this: phenytoin, ethosuximide, valproate, or carbamazepine. We got 87 answers, waiting for the others. Yeah, so perfect. More than 70% are right. It is ethosuximide is the correct drug of choice for absence seizures. Shamu is the new topper now. Coming to the next question. Which drug can worsen absence seizures? Now it is carbamazepine, valproate, lamotrigine, or ethosuximide. This is slightly tricky question.
ये केस पे मुझे आने नहीं दिया तूने.
हाँ, ये केस पे मैंने नहीं दिया. वो टाइम एक्चुअली गलत हो गया.
टाइम चला गया.
ग्लिच थी. बट सर प्लीज, यस सर, थोड़ा सा इसके ऊपर आप बताइए. Which drug can actually worsen absence seizure? थोड़ा.
See, basically the drugs acting through the sodium channels, like carbamazepine, oxcarbazepine, and phenytoin, and also sometimes these 3-4 drugs which act through the sodium channel, they can precipitate the seizure semiologies like myoclonic epilepsy or absence epilepsy. So these 3-4 drugs, they should not be a single liner for a practicing pediatrician or a postgraduate dad. These are not the drug to be chosen for the treatment of any generalized epilepsy, and absence seizure is one of the generalized epilepsy. So please, if at all you are starting the drugs like carbamazepine, phenytoin or oxcarbamazepine, the seizures could be worse. And the best example is the worsening of the myoclonic sort of seizures. Any myoclonic seizure, never ever use the drugs acting through the sodium channel. Thank you.
Perfectly said, sir. Unfortunately, we were not able to take that case, but then yes, people have given the correct answer also. Okay. Next question. What is the EEG pattern for infantile spasms? Normal, hypsarrhythmia, spike wave, or burst suppression? And as you can see, Sanjeev sir, 70 answers came in just 5 seconds. So people were actually enjoying, and this time they learned a lot. And this EEG pattern of infantile spasm, the correct answer, 72 people, I mean, out of the 77 answers, 72 are right, that it is hypsarrhythmia. So wonderful knowledge as well as the wonderful teaching. Coming to the next question, because at present the leaderboard is not changing. Shyamu, Vikas, Krunal, Jini, and SK Sethi are remaining. Rest participants, please back up. You will have more chances. What is the drug of choice for infantile spasms? Valproate, levetiracetam, carbamazepine, or ACTH? Again, 82 answers are already there and waiting for the other answers. And the correct answer is ACTH, which is rightly been said by 80 people out of 82. So congratulations to one and all. You all are winners, but you are getting different marks just because of the speed at which you are answering.
You say this, the
yes, the leaderboard is same, but Vikas Kateva is actually having a streak with correct 8 answers in a row. Yeah. So the next question. What is the most common brain tumor in children? Most common, huh? It is craniopharyngioma, ependydoma, astrocytoma, or medulloblastoma. I think I heard a voice of Tarun if he was saying something.
Yeah, the last question, you said the infantile spasm, non-tuberous sclerosis infantile spasm, ACTH
is a drug of choice. Yes, perfectly said.
If it's the tuberous sclerosis, then my drug of choice is vigabatrin.
Vigabatrin. Perfect. And that was already been shown on our panel discussion slides. Okay. So this was a tricky question. I'll just give clarification of this, but this is what is the most common brain tumor. The astrocytoma is the correct answer given by 31 people. And next related question, a double point question. What is the most common malignant brain tumor in children? Whether it is astrocytoma, medulloblastoma, ependymoma, or glioma. "77 answers. 83. Still waiting for others to answer. 85 answers. And the correct answer is medulloblastoma. Now, see, the most common A is okay, astrocytoma, but malignant is M, medulloblastoma. Now, while talking to the Tarun, he said that nowadays, this is how in our PG days we used to remember the OSCE questions and the MCQ question, most common and most common malignant brain tumor. But nowadays we do have a classification of grade 1, 2, 3, 4. Tarun, can you throw some more lights on that?
Yeah, there's malignant or benign. That's the WHO classification, how aggressive the tumor is. So grade 1 to grade 4. So grade 4 is more aggressive.
Perfect.
And it's depend upon all the tumor genetics and all. It depends upon the prognosis.
Okay. Yeah. Thank you so much, Dr. Tarun. Coming to the next question. At present, the leaderboard is now Jini, Dr. Sethi. R is the new entry, and I hope R is Dr. Rajesh Kulkarni, our friend, Eddie Brau, and Krunal. Okay. Jini. Okay. What is the most common cause of microcephaly? perinatal insult, infection, genetic, and malnutrition. It is 7 answers, and out of that, 24 are correct. Genetics. See, perinatal insult can have a microcephaly, but one of the leading cause of microcephaly is a genetic cause that has to be ruled out. Okay. The next question. What is the CSF finding in case of a Guillain-Barré syndrome? CSF will be normal, a high cells, low protein, or high protein and low cells. We got 87 answers, and out of that, 77 are perfectly right. It is high protein, low cells, a cytological protein dissociation, which is the hallmark of GBS, one of the diagnostic feature which has been seen, along with features.
The problem is it comes at the end of first week, not in the first week.
Yeah, that is what I was saying, Sanjeev sir, that it is one of the feature, but along with all other examination findings and the criterias, so which is there. Okay. Anything else which you want to say, sir, on GBS and the CSF? Fine. We move on to the next question. What is the most common cause of headache in children? Migraine, tumor, infection, or tension type? Okay, and perfect. 58 are correct answers. That it is a tension headache, which is the commonest. And at present on leisure board, it's Jenny, SKCT, R, Eddie Bravo, and Bibu. Come on, friends. We are almost at the halfway. What is the most common cause of pediatric stroke? Infection, congenital heart disease, tumor, or trauma? Yes, the correct answer given by many people, it is congenital heart disease, which is the commonest cause of pediatric stroke. Next, a double point question. What is the triad of West syndrome? Hypotonia, ataxia, tremor, fever, seizure, coma, spasm, delay, hypsarrhythmia, headache, vomiting, papilloedema. We got almost 83 answers, still 10 seconds more. 87, 88. Yeah, and out of 88, 80 are correct. That is perfectly fine. That is spasm, delay, and hypsarrhythmia. Any of the faculty, can you just throw some more light on the West syndrome? We say it is a worst epilepsy in small toddlers. Sanjeev, yeah. Any faculties? Sanjeev sir, Tarun sir, Anand sir.
Okay. So let me put it this way, that one of the most refractory epileptic encephalopathy is West syndrome, and the India is a hub for symptomatic West syndrome secondary to neonatal hypoglycemic brain injury, and so much so, I think so much so that in the Western world, you hardly see NHBI as a cause of West syndrome. They have other causes, of course, the genetic and the other issues. And the treatment is all or none. If they respond within 2 weeks. Otherwise, they don't respond. And the treatment modality is ACTH. And of
Perfect.
course, if you have a tuberous sclerosis, as Tarun
Sir,
bhai
sir,
has
sir,
already
wait.
mentioned.
Next question is of tuberous sclerosis.
Okay.
We'll talk about it, but
Okay.
then, yeah, because my quiz will be leaked.
Okay. Okay.
Okay, yeah. Yeah. Which neurocutaneous disorder is associated with S-leaf spots? Neurofibromatosis, Sturge-Weber syndrome, ataxia telangiectasia, and tuberous sclerosis. Now, when we say Ashleaf spots, I mean, out of 85, 76 are perfectly right that it is tuberous sclerosis. And in tuberous sclerosis, usually while we were studying, we used to remember that this Ashleaf spots or all other features can be remembered by a mnemonic hematomas, like hematomas everywhere, brain, skin, kidney, heart, or A for Ashleaf spots, M for mental issues like the developmental delay or a retardation, A for adenoma sebaceum, R for renal angiomyolipoma, T for tumors in the brain, O for obstructive subependymal giant cell astrocytoma, M for mitral rhabdomyoma, and A for autism or ADHD. So that is most common, and that's why I just said, sir, the next. Anything else, sir, you want to say in this?
Tarun.
Tarun.
So
Fine, we'll move to the next question. The next question is, what is the drug of choice for spasms in tuberous sclerosis? Valproate, phenytoin, ACTH, and vigabatrin. If you listen to Dr. Tarun while we were discussing about the treatment, at that time you already given the answer of this, and that is a correct answer. 84 people have given the answers, waiting for a few more. The correct answer, Tarun, thank you to you. You already said the answer, vigabatrin, and people were listening to it. So in tuberous sclerosis, the drug of choice will be a vigabatrin. Coming to the next question, in which conditions we do see cafe isolate spots? That is Sturge-Weber, Down syndrome, neurofibromatosis, or tuberous sclerosis. People have already given, 84 people have given the answers. And 67 are right. It is neurofibromatosis, which is the correct answer. Okay. Moving to the next question. I'm happy that in spite of 1030 people are still there, 84 people and playing, and they are winning the prizes. A port wine stain is associated with which condition? Tuberous sclerosis, neurofibromatosis, Fragile X, or Sturge-Weber? And 80 people are right, Sturge-Weber. So see, when we said the cafe au lait spots and neurofibromatosis was the correct answer, at that time the other conditions like the Albright syndrome, the Leopard syndrome, the Fanconi anemia can be a differential diagnosis. And when we have a port wine stain, along with that, if we have a leptomeningeal angioma or the seizures, the diagnosis of Sturge-Weber is perfectly been fitting into it. Coming to the next question, a double point question. In which disease a cherry red spot is seen in the retina? Is it Tay-Sachs? Is it PKU? It is MSUD, or it is homocystinuria? I'll request one of our faculty to say something about this once the timer is done. 83 answers are there. And 77 are correct actually. It's a Tay-Sachs disease. Please, faculties, some light on this cherry red spots and Tay-Sachs.
See, cherry red is not only seen in Tay-Sachs, but other conditions also like neuronal Niemann-Pick disease, then GM1 gangliosidosis. You may see the cherry red spot. So you have to see you have to have a holistic approach. Keep what kind of phenotype it is fitting, like organomegaly is more prominent or the neurology is more prominent like that. That's
Yeah,
it.
perfectly fine.
Yeah.
Leisure ward is almost same. Jenny, SKCT, Eddie Bravo, Bibu and Chait. Come on,
इसके
friends.
मतलब
What is the most common cause of ataxia in children? Tumor, infection, post-viral cerebralitis or trauma? And we do see few of the cases in this season in which typical season of viral, it's a post-viral cerebralitis is there. I mean, the post-chickenpox and post-measles, I mean,
Yeah.
we are seeing many cases. So post-viral is the commonest cause of ataxia in children due to the cerebralitis.
एक इम्पोर्टेंट है
Dr. SKCT is at now
प्रशांत,
top, sir, followed by
प्रशांत,
Jenny, AD
एक
Bravo,
इम्पोर्टेंट
BU,
मैसेज देना
and
चाहूंगा
Chait.
कि एक इम्पोर्टेंट मैसेज देना
A
चाहूंगा
double point question.
पोस्ट वायरल सेरेब्राइटिस
एक मिनट सर, what does Landau-Kleffner syndrome affect? Hearing, motor, speech और vision? Yes sir, एक क्वेश्चन के बाद हम लेते हैं उसको. Landau-Kleffner syndrome, hearing, motor area, speech area और vision किसको अफेक्ट ज्यादा करता है? It's almost 87 people playing. The rest have actually left, I think. I don't know how many are playing at present. But yes, 43 people are right. It affects the speech area.
Speech.
Yes, sir. Sanjeev,
Yeah.
sir, you were saying something.
Yeah, LKW is the only cause of adolescent acquired mutism,
Yes.
acute onset acquired mutism, and it has got a specific correlation with the EEG, and the treatment of choice is immunotherapy in this condition. What I was telling to this that post-viral cerebralitis, of course, it is one of the most common cause of ataxia in
Ataxia.
children. But if at all you don't have a classical temporal relationship of a fading rash of varicella and then you have an onset of ataxia, then it is okay. But if at all you don't have a clear-cut history of varicella, please don't label that condition as a post-viral cerebralitis, because we have missed sometimes the conditions like medulloblastoma because of that. So if at all in doubt, do a neuroimaging. That is what my point was there.
And as perfectly said, the Landau-Kleffner syndrome, a selective autism or a regression in her speech, which has been seen, is commonly seen in adolescents.
Mutism.
At present, Aditi is a new climber and Neer. This is a new climber. They have reached to a strict 13 now. Few more last questions, 5, 6. What is the most common cause of a developmental delay while we are dealing with this? Whether it is an infection, genetic, unknown, or environmental cause. It is 4 answers and correct answer is unknown given by many. Moving to the next. Dars is the new entrant now. By what age is myelination typically complete? This is for the postgraduate students. 5 years, 2 years, 1 year or 10 years. (82) are correct answer given answers, and the correct answer is 2 given by more than 70%. That is 2 years.
Almost.
Still, SK Rathi is at the top, followed by Jenny, Aditi, and Bibu. A double point question. Which gene mutation is associated with Dravet syndrome? Is it SCN1A, MECP2, FMR1, or dystrophin? Now, this is a question, tough question, just to see the difference between the all are actually having almost same scores. This question will be slightly tricky question. In this, the correct answer out of 84, the correct answer SCN1A. Wow, 62 people have given the correct answer. This is
Yes, yes.
a voltage gated sodium channel. This was unexpected, but I thought this is a
Very,
tough question, sir.
very learned audience.
Yeah, very learned audience.
Very
Yeah,
learned.
very
Yes, yes,
learned. I
yes.
mean, so
Yes, yes. See,
good. I mean,
SCN1A mutation is a spectrum. The child can present with a frequent febrile seizure, sometimes can have a febrile seizure, or sometimes condition like febrile seizure plus means febrile seizure persisting beyond the upper age limit 6. But a worst clinical scenario is the Dravet syndrome, where the fever is a trigger for the first seizure, but then later on it changes into a febrile seizure, developmental delayed, and this is a very refractory thing.
Yeah.
And the most important is that again in SCN1A condition, all the sodium channel drugs like carbamazepine, oxcarbazepine, phenytoin are contraindicated.
yes, that is the most common lesson, that it starts with actually a febrile seizure,
Yeah.
but then there is multiple seizures, developmental delay, and if you are using carbamazepine or phenytoin, that will actually harsh, and we call this as a sodium channel drama that is there. So good. Okay. Dr. SK Sethi still leads. Bibu, Eddie Brevo, and Sitara is now new entrant.
सूर्य कुमार सेठी है
Which
क्या हमारे?
neurotransmitter is deficient in ADHD? It is glycine, serotonin, GABA, or dopamine. Now, this neurotransmitter deficiency can lead to ADHD. And 80 answers are already been there. 81. And correct answer is dopamine, given by 70 people. So good. Now, last two questions, a double point question. What is the metabolic defect in maple syrup urine disease? Fat metabolism, glucose metabolism, urea cycle, or branched chain amino acid metabolism? I have kept few questions like this at the end so that we can just have some difference. But the audience is unbelievably giving right answers. I mean, they are very strong audience. 81 answers have been received. And the correct answer is branched chain amino acid metabolism. Great. 76 out of 82 are correct. So no more further discussion. What is the most common cause of pediatric demyelination? Multiple sclerosis, infection, leukodystrophy, or edema? Again, same 80 answers are already been there, and out of 82, say 56 are correct. It is edema, which is the common answer. Coming to the last two questions, sorry. What is the treatment of acute disseminated encephalomyelitis? Antibiotics, IVIG, surgery, or steroids? Now, while you're dealing with a edema case, at that time, most important thing is this is the treatment which can change the prognosis and outcome drastically. And 80 people have given the answers, and the correct answer is IVIG, which is given by majority. What is the most common cause of neuroregression? Infection, tumor, metabolic disorders, or trauma? And for this also, the correct answer out of 80 has been given by plenty. So it is perfect metabolic disorder, given by 68 people. coming to the next question, double point question. What is the EEG hallmark of Lennox-Gastaut syndrome? A normal slow spike wave, 3 Hz spike, or hips arrhythmia? And the correct answer out of 80, we have given a double point and time extra for this EEG hallmark of Lennox-Gastaut syndrome, which is given by slow spike wave 56, which is correct. Now the poll question last, how was the quiz? Very easy, easy, medium, and hard. So after this poll question, we will be giving you the 11 winners who will be getting total prize worth 15,000 rupees. The first person will get 3,000, second 2,000, and all 9 rest will get 1,000 each. And we are thankful to Zorvia for that. And I'm happy that 58 said it is a medium, only 7 said it is hard, and 3 people felt it very easy. So thank you so much. And coming to the top 3.
For me, the topmost is the quiz master himself. Give a big
so
round
third
of
is
applause to
Aditi.
Prashant.
Second is Bibu. And first, I hope it is Dr. S.K. Sethi. Yeah, it is Dr. S.K. Sethi is the first. And the Jenny, Eddie Bravo are the 4th and 5th. And the yeah, thank you so much. I'll just share the other winners. And the other winners, just a minute. Yeah, thank you so much. I think while clicking this, I just closed the screen, but I'll just open it again and we'll share the winners. But thank you so much. It was 108 people who were playing continuously, and we got the 5 winners, but I'll just share the rest winners in a minute. Over to our secretary, Dr. Nehal ma'am, and Dr. Jankta ma'am, and Dr. Yogesh sir. I'll just sharing the screen again. Give me a minute.
Yeah, thank you. Thank you so much for today's very motivating, very enriching, and very learning session today. So thank you, Sanjeev sir, taking through us the journey of the epilepsy, which is very much needed for all the PGs and even for the practitioners. And for that, all the panelists, which were very nice and to the point for all the answers, Dr. Anand Keshwan sir, Dr. Abhijeet sir, Dr. Debashish sir, and Dr. Tarun Gondaliya sir. So thank you so much, each and every panelist. Thanks, Prashant, for taking us the knowledge check by the quiz, and everyone liked it. So one more time, you rocked it. Thank you so much. Thank you so much, everyone. Over to you, Prashant, for sharing the results. Thank you, Zorvia, for supporting this quiz and motivating everyone with a little amount, but definitely it matters. Thank you, Zorvia.
So if you have a more participants, you can increase the amount also. Not an issue.
Yeah.
9 participants were there. Out of that, roughly 80 people were actually persistent in answering. And Dr. S.K. Sethi has given correct 90% answers, followed by the Bibu, Iti, Jenny, Eddie Bravo, Darsh, CM, Suri Babu, Chet, and Rajesh. And one more, 11th number is, just a minute, it is Sitara. So see, these are the winners. The winners are supposed to either send on email their screenshot of winning at aopgujarat@gmail.com, or they can WhatsApp me so that we can transfer them the money. I'm just sharing both the things in chat box. So they have to send it, then and then we will be able to transfer the money, and within a week we will do it. So don't be in a very hurry. But thank you so much to all 159 participants who have actually participated. Thank you.
Thank you. Thank you all. Good night.
Good night. Thank you, everyone.
Thank you, Lata. Constantly being there.
Welcome, ma'am. Good night, everyone.
Good night.